Let's now look at a class 3 drug, a voltage-dependent potassium channel blocking drug. When I'm looking at potassium channels, I know I'm looking at repolarization, and I know I'm looking at repolarization of literally any electrically active cell, whether it would be the actual voltage-dependent, whether it would be actually a neuronal cell having an action potential with sodium coming in, potassium leaving, whether it would be the fast response fiber of my heart muscle, whether it would be the nodal tissue. All of these require potassium in order to repolarize. So in a nutshell, you could imagine that a potassium channel blocker should be able to expand the action potential duration in any electrically active tissue. Well, indeed it would. And once again, if I was picking on one of these potential, I would probably choose this one on my exam. And if I had a control action potential shown here in black for fast response fiber, then what I would expect my new action potential to look like is if I do nothing to sodium, nothing to the plateau phase, it would just take forever to repolarize. And as I take forever to repolarize, I see right here the classic effect of potassium channel blockade. Indeed, action potential duration is now longer than on the black one, and as such, effective refractoriness is increased. So if this can work on any type of action potential, it would be logical that the big drug amiodarone could be used in any type of arrhythmia. And really, if on top of it we start looking more clearly at its pharmacology and realize that it's also a sodium channel blocker, a beta blocker, and a calcium channel blocker, well, that is literally the wonder drug. If it's really the wonder drug, how come we have others? Obviously because there has to be a problem with it. Here's the first problem. The half-life of amiodarone is ridiculous, greater than 80 days. You're talking upwards of 3 months for one half-life. Here are the problems. First, how many half-lives do I need to reach steady state? 4 to 5 half-lives. Remember this from general principles? 4 to 5 times 3 months. And I'm treating a life-threatening ventricular arrhythmia. Now that is borderline ridiculous. We're talking 15 months before I reach steady state with that drug. And if ever it's toxic, then 3 months later, there's still 50% of that drug in my patient's body. So it is really limited by that silly, slow pharmacokinetic of elimination. Why is it so slow? Because amiodarone loves to bind to proteins. Amiodarone has high tissue protein binding. And that high tissue protein binding, as you can see in your syllabus, is actually increasing the volume of distribution of amiodarone. That tissue protein binding comes from one key point. Look at the word amiodarone. You see iode? Iode in it stands for iodine. And did the physiologist tell you about iodination of proteins by any chance? Yeah, of course, thyroid hormones, the iodination of tyrosines in thyroglobulin. You could imagine amiodarone and its metabolites can iodinate tissue proteins. And once you iodinate, well, you're stuck in that tissue. You've made a covalent bond with these amino acids, so you're going to stay in there forever. Amiodarone with a high tissue protein binding, a little bit like procainamide, is behaving as a fabulous hapten, which now causes immunogenicity. Now, I always love to say this. Which tissue in your body receives 100% of your cardiac output? Yeah, the lungs. And if that's the case, my drug and any drug love to go in lung tissue. If it behaves as a hapten, once attached in lung tissue, it'll trigger an immune inflammatory response. Result of chronic immune inflammatory response, even in stable cells such as those of the lungs, well, you will end up with pulmonary fibrosis. As a matter of fact, many cells in the lungs are even labile. Nonetheless, chronic injury will result in fibrosing condition. And fibrosis, obviously, is not a reversible story. That means you have a drug here that causes a restrictive pulmonary disease. We'll see you in pathology, and you'll see what fibrosis means. Think of your physiopath. Think of what it would mean to total lung capacity, to such things as an FEV1 to FVC ratio. Can you fill those up for me? Are you decreasing all your lung volumes with fibrosing disorders, with restrictive disease? Are you telling me that FEV1 to FVC ratio would be normal or elevated? If you are, you're in good shape. This is a beautiful integration that you need to be aware of and ready for on your USMLE, so that as you build the question, anything that would have a link with physiopath, you bet can be brought about with graphics, with numbers, with equations. Anything that you know from the other discipline now would show with amiodarone, a drug that causes fibrosis. Hey, by the way, any other drug that causes fibrosis, just in case, if you want, annotate in the margin of your book. And I know many of you have said bleomycin. And if you've said bleomycin, you're thinking exactly as I do, a famous anti-cancer drug that could be just as well board tested for pulmonary fibrosis. Of course, nothing to do with antiarrhythmic, just linking the side effects together. What else? Hey, look at the last bullet. With iodination, obviously, I expect thyroid dysfunction. And so you know, whereas pulmonary fibrosis is really an issue in upwards of about 45% of your patients, so it's really the limiting side effect. A thyroid dysfunction is seen in upwards of 5% of a patient. Dysfunction meaning it can either be hyper or hypothyroidism. It all depends how the endocrine axis is going to regulate itself to the amiodarone administration. These two are very logical, absolutely beautiful side effect. Rarely you may see a hepatic necrosis. The poor liver is trying to get rid of those iodinated metabolites and is failing miserably. You will see accumulation of the drug in any tissue, including corneal deposits. And in the skin is a famous story on the exam. In the skin, we're going to see blue pigmentation of that skin. I think the way your board's like this is literally trying to tease you, describing to you the quote-unquote Smurf skin. That's those little cartoon midgets that scream on TV every now and then, that have a blue skin, and hoping that by just saying blue skin, they either make you think amiodarone or are completely confusing you. That blue pigmentation comes from the fact that iodination of any glycoprotein or any sugars, complex carbohydrates, results in a deep purple color. You know what you're going to do for yourself? Just don't tell anyone. When you go to the hospital next time and you see that betadine that we love to use in surgery room, you know that's iodine. It's a nice topical, of course, antiseptic. Well, take yourself a little potato, raw at this, and put a little bit of iodine on the potato, which is primarily carbohydrate. You will see the deepest, most beautiful purple color you've ever seen. That's exactly what happens at the level of the tissue of a patient on amiodarone. Unless you do autopsy, you would only see the skin. So we're only talking about the blue skin here, at least initially, while your patient is alive with that silly drug that has a half-life of more than 80 days. Amiodarone is your main class 3. Sotalol is the other class 3. To my knowledge, on the exam, sotalol is really tested for what it sounds like. You see allol, not olol, allol, in which case it is not only a potassium channel blocker, but it's also a beta blocker. It's actually a fairly selective beta-1 blocker, and thanks to this, it adds on to the prolonged repolarization, a decreased heart rate, decreased AV conduction. Sotalol is only used normally for life-threatening ventricular arrhythmias that do not respond to conventional agents.